Today, we will discuss the guidelines that support the diagnosis of acute kidney injury in the outpatient office setting. Acute kidney injury, N17.9, and the acute renal failure codes are generally used for the initial episode of care in the hospital. However, there are guidelines that support the diagnosis in an outpatient office setting. According to KDIGO guidelines, acute kidney injury can be defined in an outpatient setting if one of the following occurs in the presence of dehydration or CHF exacerbation: an increase in serum creatinine to greater than or equal to 1.5 times the baseline, which is known or presumed to have occurred within the prior 7 days, or a drop in the glomerular filtration rate greater than 30%, not to be used for a GFR drop after ACE or ARB, which is physiological. Many times, stopping an ACE or NSAID and rechecking labs later on returns it to normal. A rise in the creatinine of 25% or more is a reason to stop the medication. Anything less than that is normal, and therefore the meds should be continued. As for coding, N17.9 and N17.8 trigger HCC 135. If your patient becomes hospitalized after discharge, make sure you code appropriately. If the patient's condition is still being treated, you would assign aftercare code Z42 through Z49 and Z51. If treatment has been completed and you are continuing surveillance, assign the appropriate follow-up codes Z08, Z09, Z39. As always, say what you see. I'm Dr. Sanka, and this has been your MRA Tip of the Day.